privilege to solve complex problems in collaboration with our community partners. The center works to identify these examples of translational research and promotes and encourages this kind of scholarship with students, staff, faculty, and our community partners. So the center sponsors a whole host of things. Okay. The center sponsors a robust set of programs and opportunities, including an annual showcase of translational research, a monthly series featuring translational scholars with a community conversation to discuss their work, a robust website highlighting information about translational research and various awards, access to IUPUI's ScholarWorks, a free and accessible way to view scholarly publications, and of course, our annual keynote address. We want to take a moment to thank our community partners who have made this possible today. These amazing partnerships you see here are even more evidence of the collaborative spirit here on the IUPUI campus, and we thank them for their support. We also want to give a special shout out to our student participants today. We thank Anna Danner and Caroline Dunbar, two of IUPUI's top 100 students, for their volunteer support in assuring a smooth meeting here today. And we'll meet Anna Comer in just a few minutes when she shares her student experience and introduces our keynote speaker, President Pam Whitten. As you can see, we have both a small live audience here, along with our virtual audience on Zoom participating on the webinar. So please note that our Zoom audience can submit questions about President Whitten's keynote by using the Q&A feature, and we will try to address those questions during the discussion time. Now, to bring you greetings and an update about our Center for Translating Research into Practice, it is my pleasure to welcome Chancellor Emeritus Charles R. Bantz, who currently serves as the Executive Director of the Center, to the podium. So come on up, Charles.
Thanks, Steve. And I want to thank Steve for so many different things. I will not do that all. Sandra will. I also want to thank Nuri McLucas, who is the dynamo who puts all of these activities together, the person who will always hound you into becoming a TRIP scholar and has transformed our social media in this program. It's been incredibly helpful to us. I'm also thrilled to have Sandra Petronio beside me here today on the stage at this keynote, which is our 11th keynote. It is the 15 years of her having the idea, telling me on the way home one night that this is the most translational campus we've ever worked at. And some of you know I worked at a land grant, and so did Sandra, and we'd worked in Arizona, all these places. But by far, this was the most translational. But people didn't celebrate it, didn't celebrate their own work enough, which is another longer story. But it's a story that led to the creation of this center. And she nurtured this center, and she talked people into supporting it in a variety of ways and has championed it so many years. So I'm glad to have her here, and I'm going to ask you to give her a round of applause for that. You want to say something?
No, I think you say something for all the family.
That's always a rare occurrence, so I'm going with that one. But thank you so much. I know Sandra has so appreciated working with so many of you because she believed so strongly in this mission of celebrating the work of the faculty, staff, and students who do the work. The reason this center has been so easy in one sense is because there's so much going on the campus. And I'd ask you just to scan through the website at trip@iupui.edu, look at the TRIP scholars, literally look on social media, read the monthly newsletter that just goes on and on with all these examples of the work that people are doing. And you realize what a rich group of people this is and the work that you all do. The keynotes began in 2012. This was another one of the ideas Sandra had because she said, we keep having young faculty say, we can't do this. How can anyone do this kind of work because it has such long lead time. Oftentimes it's not always funded. And then I'm in a department that if I don't get funded, I don't keep my job. All of these issues. And we said, let's bring in scholars who demonstrate it is possible at the absolute highest level to do. So we've had an amazing variety of people. A few years ago, we had a MacArthur scholar, Shannon Lee Doughty, who came in from the University of Chicago and talked about the consequences of the debris from Katrina. It was a truly scary presentation because she had photos of the scale of half the houses being that meant. And comparison is it's about half the houses in Marion County. This is an astonishing amount of debris. She was an amazing scholar. We had Howie Giles come from the University of California at Santa Barbara and talk about intergroup theory and how to prevent violence in police-civilian interactions. Talk about a timely topic. And Bernadette Melnick from Ohio State just last year came in, a vice president for wellness and also the nursing dean, and had a set of guidance about how you can do this work. And she has evidence base to support that. Our keynote speakers twice now have been speakers who are new to the faculty of Indiana University. And this is the second one. First was Dean Hess in medicine, who came in and talked about precision medicine, which turned out to be an important priority. And the other was today. President Pamela Whitten you'll hear in a moment, has an incredible career of translational work. And we wanted to ask her to come today and speak of that. One of the characteristics of Translational Center has been to support students' engagement in these projects so that the funding that goes, for example, to the Advanced Community Scholar often involves supporting helping students as part of that work. And so we are thrilled to have today a student, Anna Kammer, you'll learn about her. She is an amazing example, both of an IUPUI student and the kind of spirit of translational work, your interest in interdisciplinary work, your willingness to take on really complex, hard problems. And she has been enormously clever about seizing the opportunities at this campus, all of which I think our TRIP scholars have. So I'm going to ask Anna to come to the stage and introduce our speaker today. Anna?
Thank you. Hello, my name is Anna Comer. I'm a third-year student here at IUPUI, double majoring in English with a concentration in linguistics and communication studies, and double minoring in computer science and policy studies. I am an honor scholar, an intern with the Life Health Sciences internship program, and a peer health educator with the Office of Health and Wellness Promotion here at IUPUI. After my undergraduate studies, I hope to pursue a graduate degree in applied communication with a concentration in health communication from IUPUI, and go on to work in the health communication field. Clearly, I have taken full advantage of my opportunities here at IUPUI in the 3 short years that I've been a student here. Although at first I was reticent to come to IUPUI, fearful that I would miss out on the normal college experience that we all see on TV and in movies, I am so thankful that I chose to come here. Like many college freshmen, I was unsure what path I wanted to take when beginning my college education. It was only in taking advantage of the wealth of opportunities that IUPUI offers that I was able to find my path in health communication. Opportunities like the on-campus jobs, internship programs, and service organizations, all of which brought me closer to the Indianapolis community. The leaders and sponsors of these opportunities make it their goal to help you navigate new experiences and support you through your years at IUPUI and beyond. The faculty and staff here at IUPUI make it clear that they don't just want to see you graduate, they truly want to see you succeed. IUPUI cares about its students and pushes them to excel in every aspect of their life. Education is important and necessary for growth, and IUPUI rightly places value on experiences as well, in and out of the classroom. The hands-on learning and community engagement IUPUI offers its students rivals those of larger universities. Not only do IUPUI attendees have the opportunity to become better students, they become, in my experience at least, better people. Lifelong learners who have the tools to make a difference in their communities, thanks to IUPUI. I am truly thankful to all of the professors, mentors, supervisors, program leaders, and peer leaders who have taken the time to get to know me and help me reach my goals and enrich my college experience. It is through their example that I have progressed on my path to becoming the professional and person I want to be. This could not have been possible without the great leadership of those in the IUPUI and IU community. And now it gives me great pleasure to introduce the 2022 Translating Research into Practice keynote speaker, IU President Pamela Whitten, who became the 19th president of Indiana University on July 1st of last year. She's the first woman to serve as president of IU in the university's 202-year history. President Whitten is an accomplished educator and researcher, holding a variety of leadership roles, beginning at Michigan State University. More recently, she served as provost and vice president for academic affairs at the University of Georgia and as president of Kennesaw State University. She was named to the Atlanta Business Chronicle's list of Atlanta's most admired CEOs in 2020. As president of IU, Dr. Whitten is well known for her commitment to putting students first and helping them succeed, something I particularly admire as a student here at IUPUI. During her first 7 months in office, she has met with thousands of students here at IUPUI and around the state to hear their concerns and hopes for the future. On behalf of the students here, I thank President Whitten for her interest in our journeys into our success. We are especially grateful to have President Whitten share her own research built upon her career as a faculty member at a number of universities, including Michigan State, where she was actively engaged in community-engaged research that translated into improving people's lives. She's an internationally recognized expert in the field of telemedicine, which she'll share more about today. She began her research, which focused in part on technology in healthcare organizations and the social impacts and effects of health technologies at a time when telemedicine was a newly emerging discipline. We look forward to President Whitten sharing her experiences as a research faculty member focused on telemedicine and to hear from her perspective as president about the role translational research can play at Indiana University and on the IUPUI campus in the years ahead. Please join me in giving a warm IUPUI welcome to President Whitten.
Thank you so much, Anna. Oh my gosh, what a treat this is for me today. And certainly hello to everybody that's physically in the room and our Zoom audience. I'm assuming our camera is in the back. Hello, Zoom audience. So you guys are so kind to invite me today to make this presentation. You're probably going to hear a little bit of the rust because I haven't spoken specifically about telemedicine in a while. And, you know, I'm used to when I'm getting up and giving a presentation, typically I am addressing some aspect of how wonderful Indiana University is, or the things that we want to do, or addressing those that maybe have issues or questions or concerns. So what a fun treat for me to kind of go back in the past, feel a little bit like it's an archaeological dig into the work that I did in telemedicine, with a specific intent to focus on those things, especially in the early days of research in this area, that were used very specifically to kind of drive and guide further implementation and adoption and use of telemedicine. So it kind of, you know, flying the airplane and building it at the same time, type of metaphor. So let me wind all the way back and make sure that everybody understands that this thing called telemedicine has been defined in various ways for a long time, and it actually dates back a long time ago. So in the 60s and the 70s, there were telemedicine projects that existed in the US and beyond. There was a famous one, for example, in the 70s that was set up at Logan Airport. If you guys are familiar with Logan Airport outside Boston, because they didn't want travelers to have to go on the highway into the city of Boston if they needed health care. This was before the Big Dig, if anybody remembers that about the Northeast. And so for a few years, patients could go in and see a doctor while they were in the airport traveling, and then not have to actually go in. And then there was a Star Pack on the Papago Indian Reservation. There was another project for a while that existed in the 70s. These were all very complicated, satellite-based, very expensive. And then by the 80s, they were all gone, and there was zero telehealth, telemedicine programs that we know of in the United States. And in the early 90s, it started to get some legs again, and there started to be some interest again. And it's really tied back to the work that was happening politically at that time when the Clinton administration was in, and there was a real acknowledgement that, oh no, healthcare costs are spiraling out of control. Oh, what we wouldn't give for those healthcare costs now, at this point, right? And so they started to look for alternative solutions. And one of the ideas was the notion of telemedicine, to increase access to care and to maybe get a handle on healthcare costs as well. And so there began to be some work in that area in the early to mid 90s. And so this is 1993, and I am dragging my husband and two of my three kids at the time, because I only had two of the three. I didn't leave one behind at that point. But I've dragged them across the country so I could get a PhD at the University of Kansas. And I was interested in technology and healthcare, but I didn't know what exactly I wanted to do with that. And so, true story, I went from Lawrence, Kansas, where the university is housed, to Kansas City, where the med school is, about 30 miles up the road in Kansas. And I just started knocking on doors. Hi, I'm Pam Whitten. I'm a PhD student. I'm interested in healthcare and technology. Are you doing anything interesting? And I got kind of sent around to 3, 4, 5, 6 offices. And then I found this guy named Ace Allen, at the time, Dr. Allen, he was an oncologist. And he said, well, we have this thing called telemedicine that started, and we have a couple of distant sites, but not really much use, but this might be interesting to you. And then from there, a research agenda and career truly was born. And so as a PhD student, I persuaded the med school to fund me one summer to study, to find out why it wasn't being used very much. At the time, there were 4 telemedicine programs in the country. And I guess when I came back, I was a little bit sassy about my recommendations. And so I was invited to join the faculty at the med school and become the first director of telemedicine for the med school for the state of Kansas, and set a research agenda, and then moved on to Michigan State eventually as well. But that's how I got so ingrained in it early on. And so remember I told you about the study that I did to find out why there was this thing in the state of Kansas, very rural, big distance challenges, looked like a perfect place for telemedicine, and why it was used so rarely. Well, in that study that summer, one of the things that I found is that, people in Kansas are like people in Indiana. They're super nice. They're super warm. They'll talk to you about anything. And I did these interviews and surveys to ask them about it and their understanding and why it was used or not used. And then at some point I realized for our communication student, Anna, I think is majoring in communication, if I remember correctly, a big number of them, I'd get them on the phone and they'd say, I'm happy to talk to you, but I don't know what this telemedicine thing is. And these were the people doing telemedicine. And so one of the early things that came out of it is just the nomenclature was problematic. Nobody knew what it was. They all called it something different. And so when one site would potentially call another site to see if a doc could see a patient via telemedicine, sometimes the other site had the technical capability, but they didn't know what telemedicine was, because that's not what they called it. And so it was this, some of the initial issues were really as simple as that. And so, that kind of mirrors the trend we saw at the time. So when people define telemedicine, and there's all kinds of definitions you'll find, but typically it's using some type of communication technology to provide some type of health service, typically over a distance. And, back in the 90s, that typically meant a patient was at one place and a provider was at another place, and there was care delivered in some way. Of course, over the years, that's morphed into sometimes data is sent and there's not necessarily 2 people, or data are monitored in some capacity to watch someone's health, et cetera, all the way to training and education, which is part of telemedicine or telehealth as well. But the early fights, and I remember going to association meetings, by the mid 90s, and there were like 200 of us in the whole world, right, doing work in this area. And we would have big fights, and people would really, really struggle over, is it telemedicine or is it telehealth? And the reason that was an issue is because I don't know if it's still the case today, but in the 90s, if you ever had the word medicine in something, it meant a medical doctor did it. And in the field of telehealth, it's often not an MD, right? It's a nurse or a therapist of some kind, or all kinds of folks that are actually providing the care. And thus was born the debate between telehealth and telemedicine. I was of the camp, call it anything you like. Let's just bring health services to people. And so if you have an opinion, you pick which one you like. I tend to use the words interchangeably as well. So, I'm at Kansas, and then eventually I moved to Michigan State, and I'm doing all this research. Can I have the slide? I have a bunch of slides, but we're only going to use some of them today. I have asked to be stopped because I could talk about this for 6 hours, so that we have time for questions or discussion at some point. So when a rude person says "Stop, Pam," I ask them to stop me so we can go. So let's put some slides up, and that's a good picture. It's not working. No. I'll just keep talking until you figure it out. Okay, here we are. So for those zooming, I have a monitor over here. I can see. I'm not just staring off into the sunset. Let's see. So we talked about definitions. Telemedicine or telehealth. Typically, people talk about it being synchronous or asynchronous. So in synchronous telemedicine, obviously, patient is at one end and the provider is at the other end, and in real time, some type of care is being done. And in the early days, typically that meant through live video conferencing, and we didn't have Zoom back in the 90s. We had to literally get dedicated broadband lines called T1 connections, or we had something called ISDN at that time, and they were dedicated calls that would occur. Now it's just a different game. And then there would be a medical peripheral device often at the same time. And so the health provider, let me just gently say, would have devices with cameras to see in any orifice they needed to see in, able to capture data, about people. You could get on a scale, it would be transmitted. Pulse oximeter would be transmitted. The data would be transmitted as well. And so that's synchronous. And then asynchronous was when, let's say it was a dermatology consult, right? And I've got the H&P, the history and physical. I know about you. The dermatologist just needs to see the nasty rash, right? You don't have to do that in real time. You can get great digital images and just send them, and that would be asynchronous or store and forward. And then we've moved into, the Wild West now of anything and everything goes, right? Combination, a little bit synchronous, a little bit of asynchronous. I guess kind of this world of hybrid that we live in. And so there's nothing that's not included now, other than it's gotten so much simpler. I did work at one point in Rwanda related to telemedicine, and one of the things that we found out, and I thought Kansas was rural until I went to the top of a mountain where they grow coffee, and there's 6 people in the village in Rwanda. And that was all about whatever you could do on a cell phone. And you know what? You can do a lot of good stuff on a cell phone related to healthcare, especially today as well. So all communication technologies are fair game to be considered part of telemedicine. We'll talk about COVID in just a minute, but as you can see from 2019, this was just a survey that was done to look at the percentage of people that have accessed some type of telehealth. And obviously there was a big bump in 2020. What happened in 2020? Anybody remember? Hopefully we'll at some point have amnesia about it. So obviously really big bump. And then as things settled down, it's kind of settled, but we'll talk about that in a few minutes. Telehealth is everywhere. Hospitals, doctors' offices, homes, schools, hospice agencies, military. I mean, I can't, there is no context where I have not seen telemedicine used in some way when it's actually needed as well. So let's see, we talked about past a little bit. So let's go back and do that archaeological dig. And let me tell you guys about a few early projects that I think are really exemplar of work that was not just translational, but intended to be immediately translational. So what we learned, we could immediately apply to the next generation of health interventions using technology, as we know it, telemedicine. So I'll give you a couple of examples of some early studies. And it was fun to me to pull some of these out and look at them. And it was weird to realize how old some of them are. So this is one that is, I think, published 25 years ago, this study. And to our students in the room, you're thinking, were you alive 25 years ago? Perhaps not. Okay. Well, let me just say, we thought we were all that 25 years ago because we were doing this initial work and we literally just were trying it. Like if you put it in and you do this telemedicine, will people use it and how will it be used and what are the issues? And that sounds so simplistic and silly at this point. But in the very early days of an intervention, when you're looking at its design and understanding it, and ultimate adoption implementation, you actually have to ask those kind of questions. And so I remember my colleagues, one of my dear friends and colleagues 25 years ago, Frances Mayer, she's actually a physician in the UK that was in the States on a sabbatical, and we did this work together. And man, you would have thought that we were inventing a vaccine for a pandemic. We were so excited at what we found at that time. So don't laugh, okay, as I go forward. So this was an initial project that we did in Kansas, and it was really kind of a needs assessment where we were looking at the use of telemedicine, particularly for elderly population in rural Kansas. And you can see, particularly the top picture, what it used to look like. I mean, literally, it was on a TV monitor, right, with a camera on top, and you can't see the peripheral devices attached, but big and cumbersome. And the nurse in this case would have to be at a special place to do this, to see the patient, right? You couldn't do this from your home at that point in any way. And so this was really one of the first systems that used full broadcast quality to actually supply home health care systems. And in this case, it was done through cable because that's what people use. They didn't use fiber. They actually used cable for cable TV. And we figured out how to tap into that and make it two-way. Again, I can see people live smirking under their masks. It's a good thing I can't see people on the Zoom, but that was really quite a thing back 25 years ago to have figured out. And so what did we find? We found that the patients readily accepted it, and they didn't care about the technology. They didn't, when they would describe it, they wouldn't talk about the TV or the camera or anything related to the technology. They would talk about it in terms of somebody checking in on me, right? Or some aspect of healthcare that I got from it. They didn't talk about it from the perspective of it being a different modality or not even that it wasn't in person when it happened. To them, it was just more about the piece of care or the intervention that was happening to them or for them over this technology. They didn't really see a difference in whether it was telenursing or whether it was in person. Visit's a visit, doesn't really matter to me. And they were comfortable discussing any medical subject. And I mean anything. Like we were even surprised and sometimes a little embarrassed at the things that they would talk about and very comfortably talk about with their nurse over the system. Again, this was a time when people thought with this mediating thing between you, you might not be willing to discuss certain things. Now, we all know the world we live in now with social media. We wish there are things people wouldn't discuss necessarily via mediated communication, but not the case at the time. And this is what a lot of naysayers would say. You're never going to be able to use telemedicine because people won't say everything. They won't tell the truth, or they'll be uncomfortable discussing and talking about certain things. And that proved not to be the case very early on in these studies. When we talked to the nurses, they liked the regular visits with patients, and they were impressed with how the speed of the positive relationship that could occur with the patient. Same thing, the acceptance of the technology by patients. But the unfavorable responses, and remember, this is in the dark ages, is, oh my gosh, glitches constantly, right? Software problems. The nurses, I'm sure some of our faculty here who I consider heroes for being able to run a class in person and have students at a distance at the same time and have learned to navigate that so beautifully. The nurses were literally at the time going, to be on a computer and dealing with a patient is just too much, right? Now, obviously, we wouldn't find something like this at the time because people have adopted it and they've gotten used to using technology in so many different ways as well. So the primary goal, of course, was to provide a framework to evaluate the feasibility of home telecare, because this was just one of the first home care projects using telecare really in the country. And so, dun, 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 we found it was feasible. What do you know? It's actually a feasible thing to do. Big deal. A lot of people read this around the country and said, okay, we can do this and we can try these projects too. And a lot were rolled out pretty quickly in those early years after this as well. And the interventions were successfully made by the nurses. Okay, here's another project. This is still a long time ago. We're still in the 1990s before you were born when this work was actually going on. this was a fun project. So this was a project back in Kansas City. Remember, I used to be on faculty at the med school at KU Med Center. And so this was a project where we put telemedicine equipment in some inner city schools in Kansas City because there was a challenge in the students accessing care because their parents typically were lower SES, couldn't get to school because they worked or they didn't have transportation. So we put this equipment in the schools, in the school nurse's office, because there were school nurses in Kansas City, Kansas. And as kids got sick, if appropriate permission had been gained, and that is no easy task in a school with parents that aren't necessarily very present, but as permission was gained, as the child went to the nurse's office, they could literally have a visit right away. And that's actually the pediatrician. That's what 1990s haircuts look like, in case you're curious. She's great doctor. So they would come in the school nurse's office, and the school nurse would be present, and then the pediatrician would actually be in his or her office. There were multiple that participated, and they would actually be able to see the patient as well. And we found it was amazingly effective. Now, there was the real-time video conferencing going on, and then the school nurse literally had an otoscope and other ways to literally, with a camera attached, so she could put it in the child's ear, and the pediatrician could diagnose ear infection. Everybody I know with kids on this call today remembers or is living through the joy of all the ear infections our kids get. They could test for strep. There were multiple things they could do very successfully. They could call in a script, and then the child could go home or go back to the classroom, depending on what happened. It was incredibly effective. Behavioral health won't surprise you. Incredibly popular application. To this day, it continues to probably be the largest application for all forms of telehealth or telemedicine is access for behavioral health services, in part because it's so uncomplicated, right? It's talking heads. And in part, as we know today, there's just such demand for behavioral health services. So any way we can fill them, this is certainly one important way to get access as well. So this one actually, it was tough at first. And it was the logistical stuff really more than the technology getting in. We ended up finding that the best way to make it work was to literally have appointments made like you would at a doctor's office. And so the school would call at 9 o'clock and say, we have a sick kid. And they'd say, great, 9:25 is their appointment. The pediatrician, in this case, was in her clinic. She'd go see a real patient at 9:20. At 9:24, she'd go next door to the telemedicine room and see the kid in the school. Then 9:27, she'd be back with a real patient. And that tended to be how it worked best back then. But the logistics of organizing healthcare continue to be such a challenge, whether it's via technology or not. It's those small real life things that really get in the way sometimes of being able to effectively deliver care, no matter how you deliver it. Okay, telehospice. Oh gosh, was this a good project? Okay, so now I have moved to Michigan, and so I'm still doing projects, telehome health or telehospice or all kinds of telemedicine projects in Michigan, and then sometimes still doing them in Kansas because of my connections there, and then sometimes some other states as well. This was a good one. This was a touching one. So this was funded by the Department of Commerce, and something I should say is a rewind, and I'm sure many of you have the same experience. To do this intervention work, to do this translational work, you have to go find external money to do it, right? There's not pots of money inside, at least all the universities I've worked at never had pots of money to go do this. And so every project that you see here was externally funded in some way by a funding source to cover the cost of it. This one happened to be the Department of Commerce. And the point of that is that you can be creative. All the funding doesn't have to come from the obvious sources that you would think about. Sometimes you can look other places and there are reasons. And in this case, Commerce was interested in the telecom infrastructure in the country. And so health applications were an easy sell. So was able to get funding from Commerce. And so this was a project to look at augmenting the traditional end-of-life care, right? So once someone is diagnosed as end of life, and you start palliative care rather than continuing in preventive care. And these were in hospice agencies where part of the care was done with the nurse going in person, and part of the care would be done with the hospice nurse doing this via a telemedicine intervention. Very, very touching. It was a joint project because I'm at Michigan State by this time, but I'm still working with people in Kansas. And you all know that. We continue to work with those that we have relationships with as well. So the telemedicine units were put at base stations in the hospice because there was no such thing yet really as doing it from your house. I mean, you could, there were some base stations you could put in your houses, but not like today, where healthcare workers can do all this from home and regularly do as well. So typically they were put at the hospice office. Hospice would have an office and there'd be a base station. And then of course in the homes of those nurses that were on call. And then of course they'd be placed in the patient units as well. And they would link with the hospice client and or the caregiver, family caregiver, because often the hospice patient wasn't necessarily in a position anymore to manage their own care. So we found a lot of very positive predictors, time and travel savings, as you would imagine, ability to supplement services and increase care quality, expanding the circle of loved ones so that family members were able to be directed to provide care so they could watch and learn as well. Negative predictors, cultural variation among offices, managerial involvement, and then the individual nurse personality. So people still matter, right? And you can have one hospice company in 5 different offices, and the culture varies amongst those 5 offices in terms of adoption and innovation and willingness to try new things and obsession or lack thereof with bureaucracy and everything in between. And so that still very much matters. But we found just amazing things with this. So for example, I'm really stretching you guys, back in time. One example is, so this was in Michigan, and this is, I guess, before global warming, when Michigan had really cold winters and lots of snow. And there was, it's in rural Michigan. And so the hospice nurses on call have to drive a long way. And so in one case, there was a patient who was literally in agony. I mean, literally couldn't stand the pain, kind of doubled over, hunched over. And the family member didn't know what to do. And they called the hospice nurse, and the hospice nurse is 60 miles each way. And this is in snowy, wintry Michigan. So that's not an hour drive. That's probably a couple of hour drive. And in the normal world, without telehospice, the patient is, remember, it's a hospice patient, right? End of life patient is in hours of agony waiting for the nurse to get there. So in this case, in this project, the nurse said, "Fire it up, let's go, let's see." And the equipment was a little less sophisticated in those days. So she told the spouse, take the piece of equipment that had the camera on it and just walk down the length of the body of the patient in play. And so the spouse did that and they walked down, and then the nurse immediately saw that it was a kinked Foley calf. And so she was able to tell the family member, just unkink the Foley calf. Basically all the urine was backed up and blocked and causing severe pain. So the family member unkinked the Foley calf. Within a minute or two, the pain was gone. The nurse doesn't have to get out in the middle of the night in the snow and winter in Michigan and drive a couple hours there and back as well. Instantly fixed. There was another case. Sometimes if you do work in healthcare, you'll appreciate sometimes it gets to you. And I mean, in good ways, it gets to you. And one example in this project was there was a mom, young, probably early 30s, who was end of life in hospice and was in a place where her 5-year-old daughter was someplace else because of how severely ill she was at the end. They were able to use this technology so that the mom could go to her child's 5th birthday party. And so the mom joined them via telemedicine and went to the birthday party. Was there care? No. Was this an important thing for the mom? Certainly. Was it important for her daughter? Absolutely as well. And so, often once these technologies are in place, they're used for so many aspects of life that, of course, are important as well. The other thing that was interesting about that from the nurse perspective, just being blunt and transparent, is, one of the things we also learned is, there were certain nurses that adopted this and loved it, and there were certain ones that didn't. And when we dug into it, remember, it's a long time ago, we found that some of the nurses that didn't were paid a salary to be a hospice nurse, but then they also got mileage at a very high rate. And if we took out 120 miles of mileage and they were, doing 2 or 3 of those a day, they viewed that as part of their income. And so telehospice was a real threat to them. It's something that was going to reduce their income. And so there were things like that in those days we didn't even factor into the equation of what might impact adoption. but things like that certainly did. And they were so important to be able to document, to again, serve as a important role in translational, activity for these projects. Telepsychiatry, woo, big one. I told you guys, behavioral health, mental health is a big application for all aspects of telemedicine. And so this is one project that was done, a telepsychiatry project that was done, again, externally funded as well. It was interesting. We were trying to figure out why we had demonstrated its feasibility and even efficacy, but there were still so many adoption issues. So this was a project with a bunch of phases, in it in terms of seeing patients. There were almost 600 consults. It was almost always scheduled. So getting over that logistical organizational part that I talked about. And the reasons for the variation in use, even within this one organization, had to do with provider roles, the different strategic goals of the organization, the culture and quirks, and certainly leadership and managerial roles, as I've alluded to before. And the difficulties didn't stem from patient adoption, and they didn't stem from technological challenges. They really stem from the providers and the organization itself. Really, the bigger barrier to use and adoption had to do with those making the referrals or using it to provide the care at that time, at least. Now, I want to tell you about this project because I always think it's important to acknowledge that when you do intervention work, particularly that you're trying to be innovative and aggressive, because healthcare is something that needs intervention so quickly, you are not doing it right if you don't have failures sometimes. At least I tell myself that. And so there were certainly telemedicine projects that we had funding for that I would deem a failure personally. Now you learn from them, and you sure better publish on this stuff to help others understand as they're working to translate this work, what doesn't work or why it doesn't work. So this is an example of a failure. This was a project funded by NIH that tested the feasibility of providing telepsych services to cancer patients. And so the cancer patients would be referred for the behavioral health, mental health services. There was research that indicated that if cancer patients, if you also manage their mental health, then their cancer care was more efficacious. And so you wanted to take care of that side so that they would be more likely to respond positively to the cancer care that they were getting as well. That was the purpose of the project. And so it was set up so that the telepsych services and equipment was coordinated and provided through their cancer center, which was located in the rural area where they lived. So they didn't actually have to travel to do it. Huge problems. Couldn't get the cancer patients to enroll, even those that in the short forms that were done that indicated depression would acknowledge it, but no way they were doing this, at all. Obviously, we wanted to figure out why that was the case. So we went on to do a qualitative study to figure out why these patients wouldn't use it, what the issues were. And of course, we found that it had nothing to do with the technology. It's not really the key, because again, in these days, people are arguing, well, it's the technology. That's why people will or won't use it. And that wasn't the case. What we found is that the people, the health professionals, the patients, were again the reasons that predicted its adoption or its non-adoption. And one of the things that we found with this was that patients didn't want to go to the place where they got cancer care and get behavioral health care. They didn't want to be there. They didn't want to admit it. They didn't want that group of people to see them in that other context, period. And we didn't know that. We didn't put that together when we were designing the project. We thought we were doing something amazing, bringing both services together for patients. And so we learned an important lesson about differentiating and breaking out those services to people. I see you nodding like we were stupid, but at the time we didn't know that yet. So. Okay, so real quickly, sidebar, when you do intervention, when you do translational work in healthcare, especially in a new innovation, you get sucked into the regulatory side, whether you like it or not, because this impacts the adoption. And I never dreamed that this would become such an active part of my life. I actually became a member of the board of directors, the American Telemedicine Association at the time, which is a national organization that grew very significantly in those decades, to deal with issues like reimbursement. There's different reimbursement challenges, obviously with Medicare, state through Medicaid, private pay. Some states have laws that say you must pay for telemedicine. Some states do not. It's still an issue. The issues of parity of service. That means, do you pay the same thing if it's a telemedicine service as if it's not a telemedicine service? Some do, some don't have parity. The issue of returning to COVID status, state licensure laws. Right now in the US, if you're a physician, you have to be licensed in every state in which you practice. As you can imagine, that's a barrier and a challenge for telemedicine. Liability, well, if you're in Indiana and you're seeing a patient in Texas, where did it happen? Because there's different liability laws, right, for different states as well. Rural broadband gaps, we saw that during the pandemic, right, with our students that lived in rural areas that couldn't access their classes and things they needed, as well. And then obviously existing health disparities certainly are an important impact and important aspect to study as well. So here we are, the impact of COVID. You can see from this slide that in about April of 2020 or so, we saw a peak. Again, that coincides with the time when the whole country went inside, but still needed health services. And suddenly everything was relaxed and loosened and people got all kinds of care this way. We came out of our houses and things have settled down. But if you see where we are now, or at least I'm sorry, where we were in 2021, a year ago, and it would appear we're still about this time, we still see about a 38 time use of telemedicine versus before the pandemic. And so that's probably not going to change. The question is, a lot of the laws that were adjusted temporarily during COVID, will they be brought back to pre-COVID time, meaning new barriers or the same old barriers or not? And I really don't know the answer to that yet. So here we are. I stopped in time for some questions. I hope. I was going to talk a little bit, of course, about IUPUI and the campus and the culture of really fostering translational work, but I would be saying the obvious, so I don't think I need to repeat that to all of you. But I will say, with all the great scholarship that goes on here, and all the wonderful things on this campus, I mean, there's so many reasons to love IUPUI as I'm learning, but certainly one of them is my appreciation for the value that this campus places on, let's do some scholarship, whether it's hard science, whether it's social science, whether it's creative and artistic, but let's do work that can impact people's lives immediately. And I think that's so important in this day and age. So kudos to everybody at IUPUI that takes that as part of their mission as well. So let me stop there and see if anyone in the room has questions or if there are magical things that have appeared in the chat that I can't see.
You mentioned it's a barrier, but it's also an opportunity because our campus is working really hard to help build the workforce of these providers, right?
Absolutely.
So we have lots of examples of that here
Put 'em
today.
out
So
there.
let's give a big round of applause to thank Dr. Whitten. You don't have to. Okay, you can leave. So we have a Zoom audience, and we want to respect their time, and we'll officially end the webinar. Dr. Whitten will be here for a little bit longer because there may be some other questions. I'm sure we all want to have a chance to thank her personally. But as we close out, we want to thank you for taking the time out today to share some research that is interdisciplinary, community engaged, student focused, and targeted to solving today's complex problems. So on behalf of the Center for Translating Research into Practice, I want to thank you for sharing your own work with us today. We also thank our student volunteers for their support of this keynote address and look forward to their continued success and involvement with our campus, not only as students, but as successful, flourishing alumni. And of course, we thank all of you for attending and sharing with us today, all your time. Please follow us on social media. We have Facebook, Twitter, Instagram, take your pick, and check out our YouTube channel where you'll be able to see this later. And we hope that you'll join us again soon, perhaps as soon as March 25th for our next community conversation featuring Dr. Devin Hensel. In fact, maybe we'll have you back as part of our community conversation because there's clearly more to talk about with telemedicine. So visit our website. You heard Dr. Bantz mention www.trip.edu for more information and to register for those events. Finally, we want to hear about your experience and we'll look forward to reading your comments to our post-keynote survey. You'll get a link following this session via email. And we hope that you'll take the time to give us some feedback. So thank you again for attending today, and we'll look forward to seeing you at other events. Thank you again, Dr. Whitten.